Rick Dean, CEO of OncoHealth. Welcome to the HealthBiz podcast.
Thank you. Appreciate you having me.
Yeah, no, it's a real pleasure. Love what you're doing, and we're going to dig into it. We'll be a little while before we get to OncoHealth because you've had such an esteemed and illustrious path to get there, and I want to talk all about that. One thing that's not necessarily on your resume, though, I'm interested in your background. What was your upbringing like, and any childhood influences that have stuck with you?
Yeah, I guess when I look back, I would say that there's probably 3 or 4 influences that have affected not only my personal life, but probably my career life as well. Early on, my mom's best friend in college had a son, same age as me. We played together, didn't see him for a year or two and didn't, kind of understand what was going on. And this was when I was 5, 6, 7 years old.
Yeah.
So right when you're entering elementary school. And he had been diagnosed with childhood cancer, and it was one of those things where we still all interacted together as he was going through care. And as a young guy, that kind of affects you a little bit when your kind of playmate is kind of going through something that you really don't understand, but you can see it physically. So that was probably one. I guess a secondary one would be, which is probably a more primary one, was my dad was actually a chronic heart condition patient for a number of years, and he succumbed to that when I was 15 years old. And
Okay.
so, kind of seeing that from a different side is kind of compelling and impactful, I suppose. And then I guess there's been many of them that have happened, but my grandmother was also diagnosed with breast cancer in my early 20s, and so I think you take kind of those things, and it creates a level of kind of more compassion and also a more kind of profound way of looking at the world, not from the way a lot of people that start companies and that are CEOs of companies are, that they were either doctors or they were nurses or they came out of academia or something like that. But I observed healthcare as a consumer and as a kind of a bystander of people that were going through a lot in their lives, emotionally and physically and so forth. So, I think that kind of got me to where I'm at, if you will, only from a standpoint of not rising to a CEO level, but more wanting to be in healthcare for the last 25 to 30 years, because it's just something that I've been profoundly close to.
And what did you decide to study in school?
So ironically enough, I'm a business major. So I went to University of North Carolina, got a degree in finance. So, thought I would be an investment banker coming out of college, and ended up not doing that. And someone dragged me into healthcare, and going back to the kind of the childhood concepts that we just talked about, I just really loved it. I loved the whole environment of trying to help. And it's such a massive problem, right? Of what can be done. And instead of taking a finance degree and putting it into, iBanking and so forth, I kind of put it into trying to grow these little companies up and help some people out.
I think if I saw on your LinkedIn profile, it looked like WebMD might have been one of your earliest stops, and probably a formative time for yourself and for the company. I know when I left business school, probably a little earlier than when you were coming out. People going into healthcare like that had nothing to do with business, but there you were already heading there. So tell us about your kind of your path. I saw WebMD and Centillion as a couple of the earlier ones.
Yeah, so I guess I had a really interesting background to kind of progress through this, because it wasn't actually WebMD that I had joined. It was Healthion, but we actually merged with WebMD. So it was Jim Clark's whole thesis of let's bring the whole world together. And I think 30 years later, we're still trying to figure out how to bring the whole world together from a standpoint of connectivity. But so I was, ironically enough, David, I was actually based in this office building where OncoHealth is based here in Atlanta today. Healthion was downstairs, and so I've kind of came back here when we got OncoHealth moved up. But from a standpoint of that, it's really been a commercial growth story. So I'm not a doctor, not a technologist. I'm a business guy, and so I understand, I think, fairly well markets. I understand and have a real interest in how things happen and how things get done. And so being a commercial facing person is what I've done a lot. So at Healthion and WebMD, it was all on their, what we called at the time, which I don't know if we really knew what it meant, our digital health business. But so that's kind of how this whole kind of thing got started. And then Went from there to, as you mentioned, a company in Andover, Mass, Centillion, which was founded by a guy named Rob Seliger, MIT engineer, been at HP for a lot of years, and had come up with this novel idea about clinical context and moving clinical applications and opening them and closing them and bringing the patient into view and so forth. And that was just that was a wonderful experience. We set in that business, really looking at it from a company that was a couple of $1 million of revenue when I joined, to a company that we exited to Microsoft about 5.5 years later. We were at about $50 million run rate of revenue, and all in the provider market, which is not an easy business to scale up at all.
No. Interesting. I remember when Healthion started up, that was back in the day, and you still see it now, where the technology person will somehow get a hold of healthcare, and they'll notice there's no way, that it could be like this in healthcare. And if we apply some, for all we know what in technology, within about a couple of years, we'll have everything solved. And they never get all the way there, but sometimes it's a success of one sort or another. You want actually, what you want is an investor like that thinks, yeah, this should be easy to solve, and put a bunch of money into a company, and then you can run with it. So
I think each kind of 4 or 5 years or so, certainly each decade, we've made a lot of progress on things that we can do. And so when I look back on those days of where we were, and I look on where we are today with real digital technologies, real things on your mobile phones, we're light years ahead of what we could do for patients where we were back then.
So the next one that I saw was sort of the progression of Humedica, which was a company founded not so much by technology people, but more by healthcare people and bankers too, as I recall.
Yeah.
And then and then its sale to Optum, and then you continuing at Optum Ventures. So that, I think, would definitely be that's a great case study. What was that one like? Yeah,
so it's a really fascinating story, I suppose, when, as a young guy, as you and I talked about before, kind of what's the world look like as you start growing your career. We had transacted Centillion to Microsoft. It was a wonderful transaction for our investors. It was a wonderful transaction for management and the employees and so forth. But when you realize that your 200-person company is now sitting in a Fortune 20 company, and you start thinking about the innovation that you might want to do in your early 40s, and are you really going to be comfortable sitting in a multi-billion-dollar company and just kind of being there, if you will, right? And a lot of the people that I had met at Microsoft are wonderfully smart people, and when I looked at it from a standpoint of my career, I was projecting out 10 or 12 years and seeing myself being in my early 50s, and you're making good money, but you're just sitting in this massively big company and not being able to innovate and do things. So I voluntarily raised my hand and said, thank you for the transaction. It was great, but I'm going to go home for a while. And that's what I did. Literally just kind of left and went home. Our kids were really small. They're probably at the time 2 and 4. And took them to daycare every morning for about 90 days. But the passion was still there. Microsoft had done something really interesting. They had acquired a technology from MedStar called Azixi at the time, which you may recall from years ago. And then they changed, of course, the name of that to Amalga. And the concept was really the right concept. It almost goes back to what Jim Clark wanted to do at Healthion, which was, let's take all this information and try to pull it together and make kind of insights from it, if you will. And so the idea of Amalga was, let's take lab data, and let's take imaging data, and let's take EMR data and claims data and put it all together. Challenge was Microsoft's technology company, and a big one. And so it was a lot of tech. It was very expensive. It was hard to sell it. UPMC and New York Presbyterian could afford it, but as you start scaling that out on a national basis, it became quite challenging to put it into marketplace. But I love the idea, right, of being able to aggregate these solutions. But we were doing it all on-prem. We weren't doing it in the cloud because it really wasn't there yet. And Ballmer hadn't proclaimed at the time that we're all in on the cloud. So one day I was sitting at Starbucks, literally, it's a true story, after I dropped my kids off at daycare, perusing through internet, looking at the Wall Street Journal and so forth. And I come across this little company, Humedica, that had just raised some money from Bain and General Catalyst and a couple of other VC firms. Looked at what they did. I literally, right there in Starbucks, emailed James Naherney, who was the banker for Bain at the time, and said, this is me. This is where I come from. I'm interested in this company. The founder, Michael Weintraub, called me the next morning. 90 days later, I was their chief growth officer, and we started growing that company up, which was a cloud-based company, right? It took all the things that Microsoft had, but it was all in the cloud. So It was a lot more affordable, and the business model was a lot better. And it's a smaller company with a really wonderful bunch of bright people there.
Well, there's some smart guys there. So James Naherney is a classmate of mine from Harvard Business School, Baker Scholar, super smart guy. I think started Bain Capital Ventures. And I remember the Zixi. I think Microsoft didn't have a lot of expertise in healthcare, so that their idea of healthcare guy was Peter Newport, who'd run the operating system division. And then I started drugstore.com, and then he came back to run the Zixi and get the Health Vault going and all that. So I remember actually the story. I'll tell you later about why I decided not to get a Windows computer, but that will be not to be recorded. In any case, so
that was the crew. Peter was reported into Peter, and he's an overly smart, great thinker, and But what they were doing, he was light years ahead of what they could actually execute on. His vision was there, but the technology and everything else was not there.
Yeah, no, very interesting. Great. Yeah. So then the Humanica arrived once it was sort of all that was promised. All that.
Yeah. Promised. So we were pre-revenue when I joined the company. And the co-founders, A.G. Breitenstein, Alan Kamer, who I think is a friend of yours, Michael Weintraub, who you know as well, were the three co-founders of that business. I came in to try to let's take this idea and this technology and let's grow it out. I had been in the provider business for a long, long time, so understood the market, understood how to take it commercial. And so that's what we did. So we scaled that business up. We had a dual-sided business. We had one business that was a provider business that was providing wonderful population health analytic dashboards to providers like Mayo and Cleveland and Ascension and others. And then we had de-identification rights to be able to utilize that data for cancer research. And so we had a life science organization that was using, before it was really called real-world data, that was using real-world data for purposes of not just cancer research, but diabetes research and CHF research and COPD and so forth. And so we grew that little company up. Optum came knocking on the door. We weren't really looking to sell it, as most entrepreneurs aren't.
That's the way to be.
They had a really interesting thesis. We met the team. We really liked them. Bill Miller and the team that was running the Optum Insight. Andy Slavitt was there still at the time.
Yeah.
And we decided to let's do this deal and let's scale, because really at this where we were at our time, we really needed to scale the business up. And that was going to require more capital, and distribution was going to be a thing as well. So we just needed capital and distribution. And we thought if we could stick it inside of something that wouldn't kill it, and that happens a lot when you sell to large companies, this could be really interesting. And then if you fast forward, the synergy case worked extraordinarily well. We weren't a massively big company at the time that we sold it, but 3 or 4 years later, we had probably 10x that business from where it was before, by putting it in that distribution channel and so forth. And that was just a phenomenal ride. And I encourage anybody who, is in a smaller company. Big companies are not bad. Optum was a great company for us. They really allowed us to grow our business. If you look at some of the executives that have come out of that Humanica business, I've come out of that. Michael Weintraub's come out of that as a chairman of Phreesia. Sarah London, who's now running Centene, came out of that business. A.G. Breitenstein, who started Folks, has come out of that business. There's just been a lot of talent that's come out of that business. And we learned a lot as well at Optum on how to run a company almost as a private company, like a public company. Make sure your financials are in order, make sure they're timely, make sure you're spending capital in the appropriate way. So that was fantastic. We had gotten to a point, though, about 3.5, 4 years into it, where I think Michael, AG, Alan, and myself had kind of, we were a little tired. We'd taken this little company, we'd grown it up, and then we'd sat inside of Optum for 3 or so years. But we still had the passion about being entrepreneurs and in smaller companies. So we met in Boston. We actually met in Cambridge and Harvard Square, had dinner one night, and everybody was kind of waiting for the other one to say, well, what do you want to do? And I raised my hand and I was like, guys, I'm tired. I don't want to go do another startup right now. We need to do something really different. And Michael and AG had this idea of, if we could take this team that we have, this knowledge that we have, we know how to raise capital, we know how to kind of look over the horizon and see trends that are going. And Optum's got a lot of capital. Could we actually deploy that capital for the purposes of looking at deals earlier? And maybe that helps Optum grow over time. So we approached Steve Helmsley and said, we've got this idea about ventures. And he said, it sounds great. He asked us how much we wanted. We told him a big number, and that's not a big number, but to the venture capital world, it's a really big number. And so that's how we launched. And so we made 4 principal investments in the first year that I was there, in some really wonderful companies, Mindstrong Health in Palo Alto, Bowie Health up in Cambridge, which you may know, and a few others. And yeah, it was a wonderful ride, kind of seeing from an entrepreneur standpoint, seeing it on the other side of being a VC for, a year and a half or so was fantastic. And really wouldn't have done it any other way. Really loved it.
Well, I've seen the progression on your resume, but you really brought it to life, and it's been some really great background, great companies, really interesting experiences, and perfect time and role for you there. So that brings us to OncoHealth, and I want to ask about what was the why did you come to the company in the first place? Was it already going? What was it? What was the stage? What drew you in?
Yeah, it's an interesting company. So I had looked at it as an investment, as well as the CEO position was open, and a good friend of mine had said you should go take a look at this company, and I had never even heard of it before. It was kind of a sleepy company at the time. It was called Oncology Analytics. It was based in South Florida. Was founded by a wonderful human being and friend of mine named Mark Fishman, who's a medical oncologist in South Florida. And what Mark had done was created a utilization management company that really had 1 or 2 payers as their customer. What he had put together was this concept of, I was a doctor for 30 years. I had to go through prior authorization. He hated it. Most providers hate it. And he said, if we're going to do something, I want to do it in a different way. If it's an oncologist only, then if I've got to talk to an oncologist at MD Anderson or Dana-Farber about a particular patient and their therapy, he hated that he got put to a nurse with other companies that he had to do prior authorization. He could just talk to the doc and they could figure it out pretty quick, and they speak the same language. So that's what he did. And he started a company that only used medical oncologists, only used hematologists. And, it was a company that started to grow from a standpoint of 2 customers. Mark's, he's not a growth guy. So he had done extraordinarily well. And Blue Cross Ventures had knocked on the door in and around 2015. The company was profitable. They said, we'd love to put some money in. Dr. Fishman said, sure, it sounds great. He put some money in. A year and a half later, the money was all still in the bank. As a VC, that's not really what you want. You want to be kind of utilizing the money to go scale. So when I looked at it, I had lunch with him in South Florida, and I just loved him as a human being. He's just a very thoughtful person, and not someone who cares about profit and capitalism, but really cares about what patients are going through, because he was a doctor his whole life, right? And so I jumped in. We brought a new management team in that probably sounds familiar. A lot of those people had worked with me in the past. And so we brought in the CTO from Centillion, ended up being the CTO here. Our head of marketing ended up being the head of marketing here. That was at Centillion. The head of sales at Centillion, who took my job when I left, became the head of sales. So forth and so on. My CFO has been with me for 4 companies now: Centillion, Microsoft, Humedica, and Optum. So we put a team together of people that I think is really important, especially in the world we live in today, where you're seeing these big downturns in the economy. We've got a management team that's, we've seen a downturn. So I think we're good, responsible fiduciaries of capital. We know kind of how to deploy it. And we started to grow that business up, utilizing technology, putting new products in the market. And so, if you fast forward from 2 health plans, what we had then, to 4 years later, we have 16 health plans that are our customers, and we're in all 50 states. And the company's been growing 40-45% on a year-over-year basis over the last 3 or 4 years.
No, that's terrific. And then you move back to the old office, so you'll finish the Healthion story, even if they
finish it up here. That's right.
So,
That's right. That's right.
Now that's good. So sort of in terms of the company itself, I understand it from the kind of physician perspective, probably around the time you were at Healthion was the time when managed care was really coming into the fore, and the doctors complained, I don't want to talk to somebody with a GED who's going to tell me what to do. So that was usually a bit of an exaggeration, but the idea of sort of peer-to-peer consultation, and that, just because someone has a higher salary doesn't mean they're going to be less efficient, because they're going to be able to get right to the answer. So that's a great concept kind of on the operational side. From the patient standpoint, what's the overall need that's being addressed? Why are health plans sponsoring it for their patients?
So if you think about our utilization management business, because today we have 3 different distinct businesses that we'll talk more about, but on the utilization management business alone, there's just a lot of prescribing that's off-label, that's off indication. cancer drugs have a lot of combination therapies as well. So where
Yeah.
Keytruda may be approved in a particular line of therapy or for a particular indication, Keytruda plus something else might not. And so if you don't really have an expert organization sitting there kind of helping the payer understand what all of that tunneling looks like coming in, it's really challenging that they're going to pay a lot of claims that they may not really need to pay. That's not based on evidence yet. That there may be trials ongoing, and we're big proponents. As soon as something's approved and ready to go, we're approving it. But it needs to be backed up by science and evidence before we're the ones that's kind of standing there saying, yes, it's okay. I mean, if you just look out, there's been since 2017, 285 new cancer drugs with new indications or new diagnosis. I mean, you don't see that in diabetes. You don't see that in anything, right? 285, because it's really expensive. Most of those drugs are $100,000 a year or more. So, it's a big number when you see that kind of volume come through a payer. And a payer is an actuarial risk-based managed care company. They're not a bunch of doctors sitting around trying to understand what that is. So there was a nice fit for us to be able to kind of get in the middle of that and be able to help the patient to make sure they got the right care.
So good. So maybe we can just lay out the three businesses. So there's utilization management, and what are the other two?
So the utilization management business creates an abundance of real world data. And if you think about how we make the decisions on our pre-authorization business, we see a lot of information from provider organizations. We see electronic medical record data, we see pathology data, we see next generation sequencing reports, and so forth and so on. Because our customer is the payer, we also get direct claims data from them on an ongoing basis.
Right.
And so and this might sound familiar, David, when you kind of think about the previous role at Humedica, we take all that information and put it into a common ontology, normalize it, and then we provide it back to the health plan with all of these kind of insights that we kind of look at and call a look inside the prior auth, right? Which is way different than being able to say your turnaround time was this and you saved me this amount of money, but really looking at the network providers, looking at the trends, looking at your spend. And so that business generated a lot of real world data. So we brought over a team that we had known from where else? Humedica. And so a lot of those guys are here now with us as well. And we kind of surrounded them with a team from other large organizations that had come from various backgrounds from MIT and so forth. So we have a life science group that's sitting up in Boston. And we take all that data. We've been fortunate that our health plans have agreed to allow us to have HIPAA compliant de-identified rights to that. And then we utilize that data for cancer research purposes with life science organizations. And so we have 6 or 7 of those life science companies today that are utilizing the complete de-identified data set for purposes of real world evidence. And then thirdly, we started kind of looking at this about 18 months ago. If you think about our pre-authorization business, we have a lot of information on who the patient is, the type of cancer the patient has, the level of disease they have, the stage of cancer, and so forth. And so if we could do something by upending the care management process of a payer today, which is typically call centers 8 to 5, they can't really do medical advice. They might do some navigation, but navigation just helps you. It points you somewhere and says, go do this, and maybe I'll help you do it, but it doesn't help me with the actual care. If I'm a patient at 10 o'clock at night and I've got severe nausea and I live in the middle of the country, what do I do? Do I go to urgent care? Do I go to ED? So we wanted to create an experience where we could really help that. So we created a product we call Iris, like the flower Iris. A lot of meaning behind that from some good friends of ours in the company. And so that is a natively mobile application that we now sell to payers. I think we'll ultimately partner with provider organizations. We'll partner with life science organizations. But that is a product that puts in the hands directly of consumers that allows them at 10 o'clock at night to click one button, get an oncology nurse on the phone within 60 seconds. And if we need to triage to order them a prescription of anti-nausea medication, then we will do that. We'll do it to an in-network pharmacy so that they can go pick it up. And maybe it's a 24-hour pharmacy so they can go grab it right now. So those 3 things are really kind of, if you think about them and the fabric of it, all combined on a data layer that everything talks to each other. And the prime example would be if a patient who was undergoing cancer treatment had just submitted from their provider a authorization request for a cocktail of cancer therapy drugs. So we look at that, we apply all the hard regimen stuff to it that we normally do, and we approve that drug. What we now do is say, Mrs. Smith, your therapeutics have been approved, and oh, by the way, your health plan is providing this particular downloadable service that's not
Yeah.
only an app, but it's surrounded by 24/7 oncology nurses as well. So those are the three products that we're involved in now.
Sounds pretty good. It sounds like a classic Michael Weintraub business in terms of selling to more than one side of the equation there. So I think of it as Michael Weintraub, but maybe it just comes from a deeper place than that.
So he will smile. He will smile when he watches this, and Michael is on my board.
Yeah. Okay.
That may give you some. Yeah.
All right. Well, that's the DNA, but it seems to work pretty well. So what is, if you think about it from the patient standpoint, what has changed? You mentioned hundreds of drugs being approved. So even, now compared to a few years ago, there's a lot more drugs. But, how has the pandemic changed what it's like to be a cancer patient?
So I don't know that it changed if you are a patient. It changed your access. It changed your access, right, to clinicians. I mean, if there's statistics out now that if you look across the U.S., there's about 32 million Americans that live in counties in the U.S. that don't have an oncologist home. I was just talking to one of our oncologists the other day that lives in Boise, and of the, 50 counties or so in Idaho, there's oncology practices in about 20% of those. So that creates an obstacle for not necessarily your primary care, but what we're trying to solve for is the moments in between. From the time you saw your oncologist on April 1st to you go back on May 15th, all of that time in between is when the side effects and the mental strain and the coping and the anxiety go on. And we know from statistics that causes worse outcomes and higher cost. And if we can get in the middle of that, we think we can take the care to them, not in a navigation kind of way, because we're not in the navigation business. That I think people are out trying to do that, and there's nothing wrong with that.
Yeah.
But it's more expensive and it's harder to actually provide medical advice to people and actually provide medical care to people. And so we have oncology nurses, we have oncology social workers, we have PharmDs, we have PAs and so forth. And we're licensing all across the country to be able to do that. Again, not to change anybody's chemotherapy regimen, but to help in those times in between when they're seeing their oncologist. That's the difference, is now we can bring some of this to them. Good friend of mine lives up in the mountains of Georgia here. It's about 2 hours from where I live. He gets his care at Emory, and that's a 2-hour drive from the mountains. There's not a good hospital up there from an ICU perspective if you need to have a problem. And a lot of problems are not just, I'm really bad and I'm running a fever. If that's the case, you really need to go find a tertiary care center and get to a hospital. But it's the Saturday night, and I had chemo on Thursday, and I've got anxiety and I haven't slept really well, but my primary care provider a month ago had provided me Ambien. And so a patient might want to know, I'm on Keytruda. Can I take 5 milligrams of Ambien while I'm on Keytruda? Can you?
Yeah.
Who knows that, right? So people navigate to web searches and try to figure that out. What we prefer them to do is click one button, start chatting with one of our pharmacists, and in moments they get a note back that says 5 milligrams of Ambien is fine. Now, how do we do that? Because we know a lot about who the patient is, right? Because we either did their prior auth, or we're getting all the data from the patient directly or from the payer.
Now, one of the things that's also come up, and this is during the pandemic, but also before, is this discussion of so-called social determinants of health. How does the social determinants of health intersect with cancer care, and do you have an impact there?
Yeah, so I think we can. And this will be, there's a couple of different dimensions around that, I suppose. One is when you think about anything that is a different medium of which someone would access something, iPhone, Android phone, tablet, or things like that. There's an accessibility issue that you have to solve for as well. The social determinants of health you have to solve for, but also the accessibility. Accessibility is, if I'm 75 years old, do I see the same font as a 25-year-old does on the phone? Might be kind of hard to do. My father-in-law's my test bed here in Atlanta. He didn't want to see small fonts on phones. So we have to make sure that we, at a data science and an algorithmic level, understand who we are talking to, who's interacting with us, and we adjust things based on that. But we also know that from dealing with Medicaid plans, Medicare plans, and commercial plans, we do see a big interest in patients who are not available to have the best care wherever they happen to be. They don't have access to food. They don't have access to transportation. They may not be able to afford their therapeutics and so forth. We think that having at least a conduit to them with something that they all hold in their hands every day, which is a mobile phone, we can help to triage some of those things. And that becomes a lot of programs that our payers already have. We can connect them into those programs, but do it all through an oncology platform like Iris.
Now, you mentioned, the example of your friend who lives in the mountains. He goes to Emory when he has to, but he doesn't always have to. One of the things that happened in the pandemic certainly was a lot of things we thought you had to go, to a medical facility turned out that could actually be handled from a distance. Have we now, explored all of those, or if we look, 5 to 10 years ahead, and for cancer care in particular, will we need to come down from the mountains as frequently, or will things have changed so that more of it could be done, let's say, at home?
Yeah, well, I think a lot of therapeutics in cancer now have become more oral based, so
Yeah.
pill, and so that allows for a certain amount of chemo to be administered at home. Doesn't take away the side effects that those drugs may still
Yeah.
have. But I think if you think forward, over the next 5 or so years, what Teladoc and others have done for telehealth, and arguably what the pandemic forced us all to do, was to adapt to a different way of communicating, not only with our families, but our doctors, our business colleagues, and so forth. And I think that's not going to stop. I think we've all gotten used to it. I was one of the CEOs in the country that said, don't get rid of our office space. We're going to need it. The world has a very short memory on things. And when this is over with, everybody will come back. Well, we've operated a global economy for the last 2 years by looking at each other this way. I
Yeah.
think you'll see a lot more of that in the next 4 to 5 years at home. I think you will see organizations who are taking risk on patient populations that will go into the home and will administer chemotherapy. And that's, it may be infusion centers that then have a place where they actually go to see a patient. But you will see a lot more of that and a lot more access. As long as reimbursements continue to be there will be a market for people to continue to innovate around it. If the government kind of all of a sudden says, we're going to pull back all of this and make it a lot harder for everybody, then you're probably going to see healthcare go backwards a little bit more.
Got it. You mentioned oral oncolytics, and one of the, of course, that's much more convenient for the patient, but from an adherence standpoint, people don't always take them. And it was shocking to me when I had a chance to see some of the statistics about just how low the adherence is on those medications. Is that your perception as well? And are there things that you do about it in order to, to increase adherence?
Well, I think like a lot of consumer applications in general, where you have an audience, right? If we have an audience with a patient, with a member, with an employee, which I still think it's funny in healthcare that it's just me, but I get called a member by my insurance company.
Yeah.
My company calls me an employee, and
Right.
so forth. But the concept of us being able
It's better than being called a ratepayer or something by your utility. So
that's right. That's very fair. Yeah,
Yeah.
ratepayer. You would know that. That's right. I
Yeah.
know that word. Yeah.
Yeah.
But the concept is really that if we have that relationship with you, Iris is a mobile device that is smart enough with the technology that we're building and have already built for us to be able to know what your chemo treatment order is. And we know that if we're doing your pre-authorization, so we see the whole therapy regimen. And by being able to see the regimen, then we can kind of be in that medication adherence front line with you that might just ping you, not in surveys and stuff. I've
Right.
seen a lot of the information and the stats where you run a really kind of blind trial and you're doing surveys. Don't send me surveys. I don't want your survey, right?
Yeah.
But if you can help me and you can interact with me, then I will give you information. And that could be just as simple as, Mrs. Smith, you're supposed to take this particular therapeutic 3 times a day. Would you like us to set you a reminder to do that? So
Yeah.
it's not pushing to it, it's asking. And if they say yes, then fine. We can set that in an automated way and we can reach out and say it. Now, do we know that Mrs. Smith took it? No, I don't. We don't have anything tracking it down the throat. I think
Yeah.
those technologies didn't work. But we know
Yeah, the businesses didn't work. That's for
that
sure.
didn't work out very well, right? But the concept would be if we have that relationship, not just with tech, but also with the oncology nurses who build a relationship with people, then I think we can help with the medication adherence, because the reason people stop taking them is it's too expensive and it's making me sick, right? And if we know that, instead of waiting to the next doctor visit 45 days later, then we can call your treating oncologist and say, this is having an effect on Mrs. Smith. Maybe we should try to figure out something to do about that.
Great. Perfect. Well, Rick, it sounds like you've made great progress and have plenty more to go. So I wish you the best on that. I want to finish off with just a question that I ask all of the guests about whether you've had a chance to read any good books lately, anything you recommend or anything you recommend we avoid.
Yeah. So I keep a lot of books. My brain's kind of always moving, so I don't have two teenage boys and sitting down with a book for a day or two just doesn't seem to happen the way that I maybe used to be able to do that. Recently read Phil Knight's book, Shoe Dog, the guy that started Nike.
Sure. I read
Really,
that, yeah.
really cool book about a guy in the first 20 years of starting a business that had every kind of up and down that you could possibly imagine. So that's one that I've read over the last couple of 6 months or so. There's another one that, because I've got teenage boys right now, that I found overly interesting. There's a guy named Dan Golden who wrote a book called The Price of Admission. I don't know if you've seen this book or not, but Dan's a Pulitzer Prize winning guy, lives in Massachusetts, and wrote this book on kind of the elitism of getting into college. It's not the Rick Singer kind of thing before this, but it's the concept that's really compelling and understanding about kind of middle America, white and Asian American people really just not getting at an Ivy or a Duke or a Notre Dame, getting a shot because of the money that comes in from the donors. And it's a really great read, especially because I went to North Carolina and I thought it was really interesting to kind of take a shot at Duke in the book. So that was pretty cool.
Yeah, sure.
And then right now I'm reading Bob Iger's book, The Ride of a Lifetime. So I'm just now getting into that. So nothing that I could say to avoid right now.
Okay, good. Well, those sound like three good ones. Well, Rick Dean, CEO of OncoHealth, I want to say thank you very much for joining me today on the HealthBiz podcast.
Thank you, David. Appreciate it very much.
You've been listening to the HealthBiz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.